It brings us to the next important talk. I think that was a talk we designed uh, for the students who are in the making as stroke neurologists. So this is I for this particular special invited talk, I request two chairpersons, my colleagues, senior colleagues, teachers, and friends. The first chairperson for this talk is Professor M.M. Mehdi Ratta. I think all of us know Sir very well. He's been a very accomplished neurologist and continues to excel in neurology care. He's a senior director and senior consultant, Department of Neurology, previously at GB Pant, and then he headed the super specialty hospital. And now he's in BL Kapoor Hospital Max Healthcare Group Center for Neurosciences. The next colleague who shall be chairing this session is Dr. Majaz Muniz, who is a professor of neurology and stroke service at the Mass Medical School affiliated to UMass Memorial Center. And we've heard him, and we're going to hear him tomorrow in a talk as well. So, and I request Professor Mandiratha and Dr. Majaz to carry over the session, please. Thank you very much.
Thank you, Professor Rohit and Professor Padma, for giving us this privilege to chair this session. Can you stop sharing, Dr. Rohit? Grateful to you for this honor, to both of you, and really appreciate. And 1 minute. So as Dr. Rohit has already mentioned, we have this keynote address. Just few minutes back, we were together, Dr. Subhash Kaul, myself, and Dr. Padma, in the AOCNR doing our assignments, and then we came and joined here. With me is very dear friend, Majaz. Can you switch on your video? Dr. Majaz Muniz. So I hope he is there, Dr. Majaz. Yeah, unmute, I see Majaz.
Unmute. Majaz, please unmute. Yeah.
Hi, Majaz. How are you? Good evening. And here we know our speaker is very dear to both of us, but I'll request Dr. Majaz to have the honor to introduce Dr. Subhash Kaul and carry on with the session. Dr. Majaz,
thank
please.
You. Well, thank you, Dr. Padma, Dr. Bhatia, Dr. Medhirata, and the organization. Thank you for allowing me to introduce somebody who's very special to all of us. It's very hard to sort of summarize Dr. Kaul in a few words. He has scholarship, leadership, humor, twinkle, and a song. So how does one combine all of this into one person? Dr. Kaul's most outstanding work has been in the field of epidemiology, which was the early characterization of stroke and dementia in India at a time when epidemiology did not even exist in a serious way. And that is reflected in his multiple publications of quality with numerous citations that are too many to recount. He has been a leader in all fields of neurology, especially in stroke and dementia, and has been the president of all of the major organizations in neurology in India. I remember meeting him in the late 90s, where he organized the first conference on on stroke in a serious way, which led to the genesis of the Indian Stroke Association, of which he also became president subsequently, and ended up with a great song. So Dr. Kaul always has, besides his scholarly activity as leadership, a very, very nice, gentle, humorous attitude about him, a twinkle in his eye, and which all reflects in his talks that he gives at any level. You will see that he would carry the same message today in the sense of combining his serious message with a number of humorous anecdotes, with a number of other thoughtful things. I don't want to take too much time, but I want to say that to summarize him, I would just say one quote from Ghalib, who was a famous Urdu poet. हैं और भी दुनिया में सुखनवर बहुत अच्छे, कहते हैं कि गालिब का अंदाज़े बयां और. Just to, it means that there are so many people who can speak well and say well, but there is one who is unique. Thank you.
Majaz, I will add, he's a naughty boy. He's a naughty boy. हर वक्त उनकी आंख में शरारत होती है. Dr. Subhash, Dr. Subhash, please.
Sir, we can't hear you, Dr. Subhash. Dr. Subhash, we can't hear you. Can't hear you.
So, thank you very much, Dr. Padma, for giving me this opportunity. And thank you, Majaz, so much for your very, very warm introduction. Thank you, Dr. Mehendirata. Thank you, Rohit, all of you. Pearls, perils, and pitfalls of becoming a stroke neurologist. Who is a stroke neurologist? I think most important is the one who is interested in strokes, who spends more than 50% of his time in strokes. He can see other things also, but more than 50% time in strokes. One who is up to date in knowledge about stroke because he has to treat it. And this knowledge keeps on changing, as you know. And one who has a fellowship training. I think this is the one which is not essential but desirable. But it's not essential. I know so many excellent stroke specialists who have not received any formal training, and yet they are of world-class quality. But I would say it is desirable because this is the first pearl. It gives you the joys of training. You get learning, you get friendship, you get a community. I did a stroke fellowship in 1994 from University of Maryland, USA. It was an NIH fellowship because at the time stroke fellowships were not available in India. But now the young students are lucky that now stroke fellowships are available in AIMS, they are available in NIMHANS, they are available in Chitra, they are available at so many places. So you need not do, you need not go abroad. But I had to do that, and we virtually used to discuss about strokes, eat stroke, sleep stroke, discuss strokes. I learned so many things for the first time. Even I had done DM at that time. I learned that atherosclerosis does not mean one single plaque. For stroke, you have to have more than 50% of the stenotic lesion to say that it's significant atherosclerosis in a vessel. I learned for the first time that 1/3 of the strokes do not have any mechanism, which even stays even till now when what you call cryptogenic or ESUS. I learned that transesophageal echocardiography is a very important investigation for knowing the cause of stroke, particularly the unknown ones. And in fact, these are all my mentors, Marcella, Sloan, Coriatti, T.R. Price. And it was really learning for the first time about what stroke is about. We also used to have weekly pizza parties. And this was my stroke nurse. Her name is Lisa. And she eventually got married to this pizza vendor and got divorced also during those 2 years in which I was there. And I attended both the functions. But that was the other side of it. But it was really fun. And after 2 years, I really got equipped myself with new challenges. And the next challenge was Mission Stroke. To start the same stroke, education and practice in our own country. And I think all these stroke specialists in our country who have started to do that have met the same challenge. I mean, there are so many of us now. I think there must be at least 50, 60 people who have done stroke, studied stroke, and then tried to start stroke awareness and start stroke units, and all of them faced the same challenge. It took a time to convince, but I tell you, that was a fun, to convince the administrators that stroke can be a different specialty which needs special attention. So in around 2000, in our hospital where I worked, which is in Hyderabad, they made a new block called Millennium Block. And I convinced the administration that we should have a stroke unit here. And on the 4th floor, this ward was given to us on a trial basis, that let us see what you can do there. So, we started with friends and all, we made different roster, and with great excitement, we started this stroke unit. And in the lobby, there was Dhanvantri God. He came quite handy because many times you had to pray to God, particularly when you had given thrombolysis to your patients. But you can see here, for the first time in any hospital in Andhra Pradesh or even in India at that time, you had 3 wings: neuro intensive care unit, stroke unit, and general wards. And I vividly remember that how exciting times those were. I remember the cases. In fact, stroke neurology changed the face of neurology. As a neurologist, you made a solid difference to the life of your patient at a time when a patient, howsoever high profile he may be, is suddenly alone, suddenly helpless. Nobody there to even give him any kind of a solid guidance. But as a stroke neurologist, you take that decision. It's a very important responsibility. And there are so many success stories. There can be a separate conference on that. A 45-year-old security officer suddenly becoming hemiplegic, thrombolized and becomes normal. A 38-year-old basic scientist suddenly becoming aphasic, getting thrombolized and becoming normal. A 60-year-old grandmother attending a marriage, falling down unconscious, getting to the hospital and getting normal. 44-year-old factory worker being brought by his colleagues in a aphasic condition and being thrombolized and getting reasonably well. 55-year-old bus driver, while driving the bus, suddenly getting into a confusion and a neurodeficit, being brought to hospital and thrombolized, and on and on and on. And I'm sure all of us friends, those who are attending this, you have many such stories in your own stroke practice life. I'm very sure about it. And as we got encouraged, we got confident in going sometimes a little bit beyond the guidelines. There was a 35-year-old software developer. At 3 o'clock in the morning, he was brought in a aphasic condition. He had already crossed 3 hours. The guideline had not become 4.5 hours till that time. But I was aware of the literature, and the literature was saying that there is some indications that this works beyond 3 hours. So we took his consent, gave him thrombolysis. He became normal, and even now he comes for the follow-up. Interestingly, there was a 75-year-old patient who was a High Court judge's mother, and she came with a right hand weakness. It was a cortical stroke, just right hand weakness. She was not able to do the puja. So the question was, can we thrombolize her or not? Particularly as per the criteria, we could not, because it was a very minor deficit. And the mother was a judge. But I counseled her, I told her, and she told me that whatever decision you take, if it was your mother. So I thrombolized her, she became totally normal, Father of a senior official from DCGI. Now, at that time, our thrombolysis was not even approved by DCGI. Our thrombolysis was approved in 2005 or so, and this is before that. And I told him that, look, this is not approved by your department as yet. He said, doctor, do whatever is good for her. So I thrombolized DCGI's father, even though it was not approved by DCGI. So he also did well. And the most important thing which happened is that mother of our own director, where I worked, she was 95 years old. She came with a hemiplegia. And even though she was 95 years old, I gave him the option. He said, go ahead. It was a big gamble which I was doing at that time, because this has also happened many years ago. I thrombolized her, and fortunately, she recovered. And our stroke unit was adjudged as the best unit in 2010. And, it was a different, we became very well known and got a lot of referrals from everywhere. Now, after that, as we were aware of literature and we were in touch with national and international leaders, Majaz and Vineet and all of them, we became quite stroke educated, and we had the confidence to break rules, but of course with caution, only with the help of literature, even though the guidelines were not there. Guidelines take time to get published. But before the guidelines, there is a phase in which you are aware of the literature. We have given TPA after 1 dose of heparin. That was Dr. Meena's sister, and she became totally all right. And today you are allowed to give after 1 dose of subcutaneous heparin TPA. But at that time, it was not allowed, but we gave it. We have given TPA within a month of a stroke. And now, as per the European guidelines, you can give TPA within the month of a stroke, because we were aware of the literature. We have given TPA after 5 hours of the stroke onset. Today morning, I asked the pointed question to Dr. Padma that can we give at 5 hours? She said, yes, you can, if you can demonstrate the diffusion flare mismatch. In fact, when we gave, we looked at this publication by Pawan Ojha, and he has published it also in our own journal, that if you can show a diffusion flare mismatch, you can go even beyond 4.5 hours, even though it's not in the guidelines, Still, there is literature which gives us confidence that you can do it. But whenever you break rules, that's what Dheeraj also said in the morning, you must have the justification what you are doing. You must have some literature support and you must have your rationale. Now, we can go even up to 9 hours if you have a CT perfusion technology. Really exciting times for being a stroke neurologist. And if you are talking of mechanical thrombectomy, you can go up to 24 hours. And this is one of our own patients. And you can see there's a large vessel occlusion on the left side MCA. And fortunately, he has a small core. And therefore, we thrombolized him. He became, unbelievably, he became all right. So really exciting times for the stroke neurologist. Now, that brings me to the question, which often we have been previously worried about, that why neurologists do not do intervention. Well, the good news is that today, a stroke neurologist can do intervention if he wants. It is not necessary to be an interventionalist to be a stroke neurologist. But if you want, you can do it. And I think we have to give credit to Dr. Padma, because Dr. Padma organized several meetings and also influenced the DNB board to create a stroke neurology, stroke interventional neurology course in the DNB. And today there is a DNB course, DNB fellowship for stroke neurology, for interventional neurology for neurologists. And now we have got very eminent people like Anand, like Gigi and Vikram, who are neurologists, and yet they are doing intervention. But what I want to tell you is that it is not must for you to do intervention. You can still be a stroke neurologist, because there is a lot more than that. In fact, I remember Majaz and myself, we were once traveling, and Majaz's sister is an interventional neurologist. And I asked Majaz, why doesn't he do it? He says, because he wants to focus on the other aspects of stroke. Because if you do intervention, then you have to devote most of your time in the lab. You cannot be doing dementia in the morning, multiple sclerosis tomorrow, and you cannot be casual about it. Intervention also takes tremendous commitment, but now you can do it if you want to, because course is there, opportunities are there. So in other words, stroke is a team. You cannot do it alone. And the team consists of emergency department, stroke inpatient department, radiology, and interventional radiology. And if you do it well, then you can get even awards. And in fact, this is I'm showing you from my own institute back, this diamond status from World Stroke Association. It is given for being up to date and efficient in acute stroke care. And I'm sure many centers in India must have got this. But remember that stroke neurologist also automatically becomes a researcher and mentor, because he puts so much of effort and study in this that he becomes a researcher and mentor. And almost all of us have published. This was our publication by one of our students on the predictors of improvement following TPA. And we have also mentored people, initiate them into thrombolysis through telestroke. Dr. Padma is a big example of that. I think she has taught each one of us, but almost all of us who do medicine help our friends through telemedicine, even through our own personal mobiles, to how to initiate thrombolysis. And the extreme of it is now mobile stroke units, which have started in Kerala or Chennai in our country, but all over the world, they are an in thing now. This is Jim Grota. He is one of the most famous, eminent stroke specialists of US. He was former president. He's 75 years old, and now he is the president of the mobile stroke unit network in USA, even at the age of 75. So real exciting stuff to be a stroke neurologist. You will almost never retire in this. Now, please remember that stroke is not just thrombolysis. It's much more than that. It is very exciting to see crescendo TIAs, when you will get hundreds of TIAs over a few days. And I remember I had one such patient. We always consult each other. I have so many times talked to Shelja, to Padma, what to do. And I remember I called Padma recently when I had these crescendo TIAs. She told me, don't worry, keep on watching him. This is a stroke-prone period. And after some time, stroke-prone period will wash away. And that's exactly what happens. No thrombolysis here, but very exciting. And Dr. Kaplan is one of the idols for all of us. we get as a stroke neurologist, you get an experience to share your experiences with all these worldwide leaders, particularly in these days. We had invited him there. And one of the things he told us is that make stroke fun. Write your experiences and publish them. That's how you are in contact with your entire community. And I can just show you some example about one young person who came with an unknown mechanism stroke, and finally it turned out he had a bicuspid valve and there was an infective endocarditis on that. This is one patient of ulcerative colitis who was having bleeding ulcerative colitis. At the same time, by the same mechanism, she was having a cortical sinus venous thrombosis and she was thrombolized, so on and so forth. And I think all of us have done that. I'm just giving you an example. This is the latest thing, cocaine vasculitis. You know, drugs have arrived in India. When I was in US, I thought it happens only in Baltimore. But no, it's in Bangalore, Hyderabad, Noida, Gurgaon, everywhere. And this is one of our medical students who had this cocaine vasculitis. And this is what all he was taking, some cocaine, MDMA, LSD. And this also we are trying to spread the awareness through publication. And when you are a stroke neurologist, you know, the world has no boundaries at all. This is about 20 years ago, this photo. Shirish Hastak, stroke specialist from Bombay, Dr. Vijaya, one of the pioneers of stroke in India, in Guntur, who is here right now. This is Dr. Suvarna, my colleague. And we made our bridges with Hachinsky. And Hachinsky is a stroke and dementia expert. And inspired by him, Dr. Suvarna, her whole career became into the stroke cognition. And along with Hachinsky, she wrote these important articles in important journals, Stroke Prevention Strategies in the Developing World. And finally emerged on her own, studying the impact of bilingualism on cognitive outcome after stroke. This is one of our own students who worked with Vijay Sharma from Singapore, whom you heard this morning, in validating the transcranial Doppler with magnetic resonance angiography, which was published in Journal of Neuroimaging, a US journal. So sky is the limit. Once you are on this path, sky is the limit. You connect with the basic sciences also. I just came across one geneticist, Anjana Munshi. She just took some samples, family history of a patient, and became herself one of the world-renowned stroke geneticists, and published extensively on genetics of ischemic stroke. Then as a stroke specialist, you understand hypertension, you understand diabetes, you understand heart disease, you understand hyperlipidemia, and you understand that these risk factors can lead to stroke, and you educate your patients on their stroke risk. You are almost like a teacher. In late in the world, doctor means teacher, and you can reduce them from their high risk to low risk. And again, for public education, I think Dr. Mehendiratta will remember, Dr. Padma will remember, when we did for public awareness as our brand ambassador, we connected to Rani Mukherjee, our film actress, with the help of Shirish Hastak, in order to spread. So the goal was the same, just to prevent stroke by awareness about the risk factors. Now, those were the pearls. What are the perils? First is that you have to be available 24 hours, right? Anytime a stroke can occur, your phone has to be always on. There is no excuse that the battery has gone, our connection is poor and all that thing. The neurons die by that time. And you cannot attend a party on a call day. It has happened with me because some of us who attend parties, we are not same after 1 or 2 hours, and after that it becomes very difficult. So when there is if you are on a call, and many times we are on call many days, you cannot attend a party. And most strokes don't arrive in time. That's a big, problem, particularly in the initial days, but even now also. And I think all of us have given lectures, published in newspapers, 3-hour solution of a stroke when it used to be 3 hours. And in fact, I gave this interview and this article, and the newspaper published it, but it gave somebody else's picture here. And I was very shocked, and I told my wife, look, they have given somebody else's picture. He said, yes, he's better looking than you. That's why he has given somebody else's picture. We also wondered about what are the factors influencing non-administration of thrombolysis. There are so many, like economical problem with the patient or like fear. But one of the important factors which we noticed is that sometimes the patients are looking for a particular doctor. They are looking only for Dr. Padma or Dr. Rohit or Dr. Mehendiratta or Dr. Kaul, and in that process the golden hour is gone. So this also we learned. So we made it very sure that there is no need of a big doctor. The first available doctor should thrombolize. Now the other peril is that, patients expect prognosis. They want us to prognosticate on the day one, which is very difficult in a stroke in all cases. There are uncomfortable situations. When you prognosticate that the patient will do well, he has a mild lacunar stroke, and then he suddenly worsens. And other complications also. These are the perils. And you can get over them, but you have to be aware of them. This will happen. This was a 90-year-old man, one of the board of directors of our hospital. He came with a very mild weakness of his foot. I gave him good assurance, don't worry, you will be all right after 5 days. And on the third day he worsens, and to my horror I found that from one lacunar stroke, the whole territory was gone. There are different mechanisms of it, but what I am telling you, this is a peril, that your predictions may be correct 90% of the times, but 10% you may go wrong. And then sometimes there are complications also. You see, if you take this evidence-based chart from the American Stroke Association, when you take class 1 recommendation, class 1 level A evidence, it says benefit is much more than risk, but there is risk nevertheless. That we have to be aware. So some good patient whom you have thrombolized unexpectedly may get some complication. So we have to be aware of this fact and factor this in. Now these are the post-thrombolysis bleeds, and you know, if you get the PH2 kind of a bleed, it is a real mood spoiler for us. It doesn't happen usually, but once in a while it may happen. In fact, we looked at that also to identify, is there any particular reason why some of them bleed? Well, there are many reasons which you will know, but still in 5 to 10% you never understand why a patient bled, and this we have to counsel the patients. Similarly, you know, there are some things which are not even mentioned in the guidelines. I think Rohit Bhatia may remember, this is one of the patients who, following a cardiac stenting, suddenly developed this cerebellar hemorrhage. Now, cardiac stenting requires him to take double antiplatelets, and he has got a cerebellar hemorrhage. And you know, cerebellar hemorrhage may need a brain surgery also, for which they want you to stop your antiplatelets. So what do you do in those situations? Because guidelines are not there. So anyway, we consulted the cardiologist and managed it with half dose, and I talked to Rohit also at that time, and eventually the patient became all right, right? Similarly, you do right and left these stenotic carotid reperfusion surgeries or stenting, but once in a while you may get a complication like a hyperperfusion syndrome which this patient has developed. So guidelines don't apply to individual scenarios. They are overall roadmaps. But we talked about 3 months of dual antiplatelets, but in some patients of recurrent stroke and bad ICAD, we have to go beyond 3 months. I think Rohit Bhatia is doing a ICMR trial on the same topic. And we don't want to combine aspirin and oral anticoagulants, but sometimes you have to do when you have got atrial fibrillation with the acute coronary syndrome. So as a stroke specialist, there will be situations when you will have to bend the guidelines a little bit in the favor of patient. Right? And it will be accepted, and as a stroke specialist, it will be accepted from you. But important thing is that you have to spend time in counseling the patient, in making them understand. You yourself have to have vast reservoirs of patients, because sometimes it will seem to you as if the patient is blaming you, his attendants are blaming you. You should not be put off at that time. You cannot afford to be angry or impatient. You have to be a vast reservoir of patient and just listen to the patient. And lastly, the pitfalls. You know, it is said hindsight is the best sight, but then it is the hindsight. Anybody can be brilliant in the hindsight. Mimics and chameleons. Mimics are like hypoglycemia, post-ictal palsy, drugs and migraine. It's not such a big problem because even if you thrombolize them, it's okay. But still, it is better not to spoil their money and then to expose them to risk, but sometimes it happens. But chameleons are the ones which are more worrisome because they actually are strokes, but they may manifest as a BPPV, benign positional vertigo, just as confusion, just as wrist drop, foot drop. I myself committed these mistakes. There's a wonderful presentation paper in Practical Neurology on atypical presentation of acute strokes. And you know, it may look just like a ulnar nerve palsy, just like a radial nerve palsy. And the lesion may be in the cortex. That's called hand knob sign. And diffusion weighted, it was many times repeated since morning that in acute stroke, sometimes imaging can be normal. That's okay, but sometimes the imaging can confuse you. Please remember that in acute hemorrhage, sometimes can mimic an acute ischemic stroke on the diffusion. If you see this is just a diffusion intense lesion, there is a little bit of a heterogeneity, some hypo-intensity on one side, and that is the clue that it is not a pure infarct. There may be either a hemorrhagic conversion or it may be hemorrhage itself. So whenever you have a diffusion abnormality, always look at ADC, and more important than ADC, always look at GRE. Now, this is one of the patients who came with the acute cerebellar syndrome, and you can see there's a small here. I was about to thrombolize him, but I don't know, through some providence, we looked at his GRE and it's a bleed. And in acute diffusion, a bleed can just look like a stroke, so we should never fall in this pitfall. Always look at GRE also, always look at ADC and then make a decision. And another thing, very important thing you must know is that amyloid spell is a relatively newly described entity which presents as a TIA, focal neurological deficit. And this is one of the publications in practical neurology where a patient came with a focal neurological deficit and it was thought it's a TIA. He was given aspirin and after 1 month he came with a massive bleed. And many times, unfortunately, amyloid spells cannot be detected by CT scan. Only MRI detect them because of these sulcal hemorrhages. So these are some pitfalls in which one may fall. How to avoid the pitfalls? I think mindfulness while seeing the patient is extremely important. We cannot afford to be absent-minded. We have to do like mindful meditation. Similarly, we have to do mindful consultation in every patient. Life is short, art is long, opportunity fleeting, experience treacherous. Sometimes your own experience misleads you. You think, oh, I have seen this patient before, but no, this patient may be different, which may make judgment difficult. In fact, I was asked to once write an editorial on acute stroke care pathway. And I said, we should be very careful in just pushing the patient on a stroke care pathway. I wrote, will the journey be smooth? Because sometimes there can be hiccups in the journey. I would highly recommend you to read this book, international bestseller, Thinking Fast and Slow. And when it comes to acute stroke, think fast. You have to think fast. But at the same time, at the back of your brain, also think slowly. Am I dealing with something else? Is it hyperglycemia? Is it post-ictal? So think fast and slow rather than just quickly putting the patient on a pathway and telling, okay, bye-bye, now you are on your own. Don't do that. Pathway should not become ropeway. You may have to take him out of the pathway and treat him for something else which he has. So dear friends, in summary, I would say stroke neurology is fun, provided you love to prevent the stroke and treat the stroke. If you don't like stroke, then you should not become a stroke neurologist. 24 hours commitment to stroke care and up-to-date knowledge is must. Fellowship is not must, but it is desirable, particularly if you want to do endovascular work also. I can promise you that you will have great professional satisfaction by your timely decisions. You will counsel patients to stay invested in life despite varying results, but you will be a great counselor. You will understand that how you will help patients. I remember I have seen once Dr. Kaplan, one patient came to him with hemiplegia. He said, my arm is not moving, my arm is not moving. Kaplan told him, but there are so many things which you can do with the paralyzed arm. He said, what else can I do? He said, you can watch a movie, you can watch TV, you can still love your children. That kind of counselors we become when we become a stroke neurologist. You will have a community of professional friends and colleagues around the world. Of course, there will be occasions when you will fail. There will be occasions when you will even fall after taking a decision which you thought was right. That will happen. But it's better to have loved and lost than never to have loved at all. Thank you.
So I just thought on behalf of the entire team out here and on behalf of the Stroke Summer School, thank you so much. Subhash, you know what? There was never any hesitation as to who would be giving the keynote address because we wanted at least, if not all, everybody, all those youngsters who are attending here to take up stroke. And I'm sure at least all those people that me and Rohit were unable to convince so far, just for your one lecture, I can see those gleams, springing out of, these little ones' faces at fag end of the day. So that's the power you have. God bless
Thank you.
you so much.
Like I said, an excellent lecture as promised. And Dr. Kaul never fails to deliver.
Thank you, Majaz. Thank you. Love you. You're the inspiration. At the Kovalam beach.
Well, so with this, I think we should wrap up the session. An excellent session. I think Dr. Kaul, as Dr. Padma said, made a great impact on the young people who want to do stroke. And I'm sure there will be many more. Thank you.
So thank you, Dr. Kaul. Thank you, Dr. Majaz. I think we have a news being shared here that India, of course, I'm not updated, but India won a gold medal for javelin throw in Olympics 2021.
What about wrestling?
Yeah, the first gold. Subhash, see, you're such a good omen for us.
Okay. Thank you. Thank you.
So thank you, Dr. Majaz. Thank you, Dr. Subhash, Dr. Mandiratha. I think that was a wonderful lecture, as Dr. Fatma has already alluded to.